The answer is absolutely avoid it in majority of cases. The important thing is that this is actually more true for women who are over the age of 55 years, and we call it them basically postmenopausal. When I was a trainee, maybe about 15 years back, I was always taught if it is a bigger tumor, let's say 4-5 centimeters or any sort of a lymph node involvement, automatic option is that we give chemotherapy. This is no longer true. It's actually the absolute false answer now. There were 2 landmark studies which has basically changed the practice in Australia. First one to come is basically this study called TAILORx, which looked at a genomic assay platform called Oncotype DX. So what it did was it recruited about 10,000 patients who are lymph node negative. So it's a reasonably large tumors, even up to about 5 centimeters, but no lymph node involvement. And they've analyzed these tumors, not looking at the tumor size or the traditional markers or anything like that, purely based on their signatures, looking at a genomic score. And the score ranges from 0 to 100. And what this score, a single score, did was it sort of categorized patients according to low risk, intermediate risk, and high risk. What this study showed with 10,000 women. So we are very confident that this was done in a proper scientific manner without harming the patient. So this can actually be applicable to you if you're having a breast cancer. So what it showed was that high genomic score, so that's like 26 is the cutoff in that study. That's just an arbitrary number. You don't need to worry about it because we can interpret that. If it is 26, yes, you would definitely benefit from chemotherapy. Majority of women who had 21 or below did not benefit from chemotherapy, even if it is a large tumor. So that is, again, we are moving away from this anatomical, that means the tumor size, the lymph node status, etc., but actually looking at the underlying biology of the cancer to give us more information, what type of cancer this is. Size is just one component. But there are more important things, especially for like a smaller, fairly smaller tumors. The biology is significantly more important, and this assay, an Oncotype DX, actually gives us very accurate information. If you've already done a biopsy, you don't need to do any other investigations. They will extract some DNA and some molecules out of that biopsy, and they can actually perform this platform, and it is having a reasonably quick turnover as well. Advancing further, the RxPONDER, which recruited about 5,000 women. This is again a massive study. What it basically showed was that even with 1 to 3 lymph nodes, there are certain women which we could completely avoid chemotherapy altogether. I mean, node negative cancers, I probably expected that's right, but 1 to 3 lymph nodes, when this study, this is kind of old now, but that definitely showed that it is safe to just rely on this genomic score, even for women who had at least 1 to 3 lymph nodes positive cancers, and avoid chemotherapy altogether. The 3 key takeaway messages is that no longer we are only looking at the receptor status and the size of the tumor or the lymph node status. Biology of the cancer is very, very important, and it gives you more accurate prognostic information and sort of direction towards treatment as well. We can potentially say, based on these studies, we have done what we call genomic profiling. We get a nice score which categorized to low risk, intermediate risk, and high risk, and depending on that have absolute clarity in terms of giving treatment, whether this patient benefits from chemotherapy or can I avoid chemotherapy altogether. And that's a very nice scientific way for a treating oncologist to decide whether the treatment requires chemotherapy or not. So if you can access that, this is definitely accessible in Australia. If you can access that, that's the best probably test to decide, especially for early breast cancers going forward.